Good afternoon, everyone. Thank you all so much for joining us today for connecting women to healthcare through HRSA's programs. I'm going to turn it over to Nancy Maternal-Smith, the Director of the Office of Women's Health at HRSA.
Thank you so much, Helene. I really appreciate it. And thank you for your leadership on this important event today. So good afternoon and welcome to today's event on connecting women to healthcare through HRSA's programs. This event is in celebration of National Women's Health Week. As Helene said, I'm Nancy Maternal-Smith. I'm the director of the HRSA Office of Women's Health. And this event today was developed in collaboration with HRSA's Bureau of Health Workforce, the Federal Office of Rural Health Policy, and the Bureau of Primary Health Care. And it's part of the Office of Women's Health Leadership Series. Next slide, please. During today's event, you will hear how HRSA-supported healthcare settings are increasing access to women's health providers in high need and underserved areas. The National Center for Health Workforce Analysis, located within the HRSA Bureau of Health Workforce, will share some women's health provider data. Then we will hear from two organizations that receive funding from HRSA to connect women to healthcare. The West Virginia Rural Maternity and Obstetric Management Strategies Collaborative is a grantee with the HRSA Federal Office of Rural Health Policy, and the Union Community Health Center, located in the Bronx, receives funding from the HRSA Bureau of Primary Health Care. We've also set aside a few minutes for questions at the end, so please use the chat box to raise any of those questions that you might have throughout today's presentation. The transcript of the presentation will also be made available on our website after the event today. Next slide, please. Great, thank you. So before we get started with our speakers today, I wanted to share briefly a little bit about our agency. And as you get to know us, please help us also get to know you by adding into the chat your name, your organization, and where you're joining us from. The Health Resources and Services Administration, or HRSA, is an operating division of the U.S. Department of Health and Human Services. And we support a broad range of programs to provide healthcare to people who are geographically isolated, economically or medically challenged. Every year, HRSA programs serve tens of millions of people, including people with HIV/AIDS, pregnant women, mothers and their families, and those otherwise able to access quality healthcare. Specifically, my office, the Office of Women's Health, provides leadership on women's health and sex and gender specific issues to improve the health, wellness, and safety of women across the lifespan. And we've partnered with several HRSA programs today. The Bureau of Health Workforce strengthens the health workforce and connects skilled healthcare providers to communities in need. The Federal Office of Rural Health Policy works to increase access to care for underserved people in rural communities. The Bureau of Primary Health Care funds health centers in medically served communities, providing access to affordable, comprehensive, high-quality primary health care services for people who are low income, uninsured, or face other obstacles to getting health care. Next slide. The HRSA Office of Women's Health provides leadership on women's health and sex and gender specific issues, and we're part of a network of women's health offices across the department. We work within and outside of the Department of Health and Human Services to improve the health, wellness, and safety of women across the lifespan. Next slide, please. And our event today is being held in recognition of National Women's Health Week, which is May 14th to 20th. And for this event, we join with the HHS Office on Women's Health to encourage and remind women and girls to reflect on their individual health needs and take steps to improve their overall health. This year's theme emphasizes whole health, physical, psychological, emotional, and social well-being, with a focus on primary care. We also want to celebrate the 1-year anniversary of HRSA's launch of the first ever National Maternal Mental Health Hotline. And this hotline launched on Mother's Day in 2022. This service is available 24 hours a day, 7 days a week, 365 days a year. And it provides free, confidential emotional support, information, and referrals to any pregnant and postpartum mothers facing mental health challenges and their loved ones. So visit the webpage that's linked at the bottom of this slide to learn more about the hotline and to order and download hotline materials. Thank you so much for helping us spread the word. HRSA is on 4 social media platforms, and we encourage you to follow along and share our content on Twitter, Facebook, LinkedIn, and Instagram to stay up to date on the latest HRSA news. And our account handle on each platform is @hrsa.gov. Additionally, we encourage you to sign up for HRSA's e-news, a biweekly email of comprehensive HRSA news, and to sign up for our press releases. And you can also visit our website listed here for more information about all of our programs. And with that, I'd like to turn things back over to Helenka to get us started with our first speaker. Thank you so much.
Thank you, Nancy, for that welcome. My name is Helenka, and I am a public health analyst with the HRSA Office of Women's Health. It's my pleasure to introduce our speakers to you today. Our first speaker is Steve Pagula. Steve is the chief of the Workforce Analysis Branch in the National Center for Health Workforce Analysis. Prior to working in NCHWA, he was an economist at the Bureau of Labor Statistics. He has a master's in public policy and management from Carnegie Mellon University.
Thank you, Lenka. It's great to be here today to chat with everybody on this very important topic, and looking forward to providing a little bit of data on the women's health workforce that we have here in the National Center for Health Workforce Analysis. So on our next slide, I just wanted to go over very briefly a quick agenda. After this introduction, we're going to look at hopefully 3 aspects of the women's health workforce: a snapshot of the current workforce, looking ahead to the future workforce, and also talking about some work that my organization, NCWA, the National Center for Health Workforce Analysis, did on the maternal workforce not too long ago. So let's move on to our next slide. Just a quick introduction to our National Center for Health Workforce Analysis, or NCWA. We publish data on a lot of different occupations and areas regarding the health workforce. So we really see our role as making sure that there's accurate, reliable, accessible data when it comes to health workforce out there for anybody to use. And what we're going to talk about today, the example I'm going to use for women's health is obstetrics and gynecology physicians. And I just wanted to note up front that, of course, those aren't the only people who are providing women's health care. There's numerous occupations and organizations that do that. But just for the sake of an example, I'm going to use OBGYN physicians as we go through. So let's move on to the first part, which is taking a look at our current workforce. And the best way to do this is using one of our existing applications. It's called our ARF, or Area Health Resources files. So ARF is a collection of a lot of different data sets that relate back to the health workforce. And part of that is data on the number of clinicians practicing. And one of the real strengths of ARF is that it's available at multiple different levels of granularity in terms of geography. So that would include state level data, national data, county level data where accessible. And we have that, and we've externalized that through our ARF dashboard, which I'm going to show you in just a second. And I just placed the URL in the chat if folks are interested in that. So I'm going to start sharing my screen right now. And hopefully everybody can see my area health resource, our area health resources files dashboard. This is available on our HRSA data warehouse. And it's something that we've developed to make sure that folks can easily access a lot of the data. So what I'm going to do right now is just to run through very, very quickly and see how we can take a look at OBGYN physicians data and just really quickly look at an example that I put together. So here I would go down, I'm simply going to select physicians and select for their professional subcategory obstetrics and gynecology. I'll touch on what these population categories are a little bit later, but we'll just keep them at all for right now. And I will select my home state/Commonwealth of Pennsylvania as an example. And when you click submit, you'll notice we get here a graph or a visual representation. And let me kind of zoom out a bit for the state of Pennsylvania. And let me just go up here to one of our counties. This is Venango County in northwestern PA. And you can see here that there were 3 active OBGYN physicians in Venango County, serving a population of a little under 50,000 people. And we also try to include a rate whenever possible to kind of standardize things, because we realize counties and states are of different sizes. So the rate is the number of, in this case, OBGYN physicians per 100,000 population. So you could go around here if you just wanted to look at it. We've got the scale down, or the legend with the scale if you wanted to check out a particular county. You can do this for all the different counties and all the different states in the US. Using Pennsylvania, though, I think it's really interesting to look at the tabular output, which I've scrolled down to right here. And we can sort it on a number of different ways, but one thing I wanted to sort on was the total number of OBGYN physicians. So for those of you who are familiar with Pennsylvania, it's probably not as a surprise that Philadelphia County, near where Philadelphia is, and Allegheny County, where Pittsburgh is, have the 2 largest number of OBGYN physicians because they have a large population that they serve. But if I sort it the other direction, you can see there's a number of counties in Pennsylvania that have 0 OBGYN physicians in them. So just going through Cameron, Forest, Fulton, Greene County, Juniata, Perry, Snyder, Sullivan, Tioga, there's a lot of them out there that have 0 OBGYN physicians serving their population. And there's quite a few that just have a single one as well. And some of these, like Pike County, there's a good number of people there. So 60,000 people are being served by a single OBGYN physician. And just to quickly note, if you wanted to, for the population here, if you wanted to limit it, say, to the female population, and if I did that, for example, I could also even subset it even further by looking at, let's say, the Black or African American female population or the Hispanic or Latino female population, if you really wanted to hone in on the population being served there. So that's just a very quick overview of our ARF data. And just to give you an idea, there's a number of occupations that we have in there. It's not just physicians. And I definitely encourage you to take a look if you have any interest in just seeing kind of what the most current snapshot of your data of your workforce is. We also try to cite the data down here whenever possible, so you can see where they're coming from. This one, the physician data, are coming from the American Medical Association master file. So with that, I'm going to stop sharing and we can switch back to our presentation real quickly. And I would like to then kind of turn things to the future workforce. So NCWA, our National Center for Health Workforce Analysis, we also publish a good amount of data on workforce projections. And the reason we do this for a number of occupations is that for many of these occupations in the health workforce, it takes quite a bit of time to educate, train, and then certify and get a clinician or provider out there into practice. So for example, if today on Wednesday we say, well, there's a shortage of primary care physicians, on Thursday, we just can't make new primary care physicians. We have to really invest a lot right now if we want to, let's say, minimize future shortages of primary care or OBGYN or a number of different types of professions that are out there. So our projections help us identify where those shortages might be the most acute and where we'd want to spend some of our resources, if possible, to hopefully limit or mitigate those particular shortages in the future. So I'm just going to drop a we're going to move now to the projections dashboard. Let me put a, gonna try to drop that into the chat really quickly if it will let me. And I will start sharing my screen again for workforce projections. All right, well, hopefully everybody is seeing my workforce projections, our workforce projections dashboard right here. And the workforce projections, let me zoom in a little bit. There are over 100 different occupations for which we have projections. And most of them, actually all of them right now, are projected from starting in 2020 to 2035. So I'm going to use obstetrics and gynecology physicians again. I'm going to click on women's health, click on that, OBGYN physicians. And you might notice that there's really two components to our workforce projections. There's the supply of and demand for each particular occupation. So for example, this column right here is looking at supply. And from 2020 to 2035, the national supply of OBGYN physicians is going to decrease by 3,430. And just a quick note, these are in terms of full-time equivalent or FTE physicians or workers. Conversely, the demand for OBGYN physicians is going to increase. It's going to increase by 5%. It's going to go up to 2,360. So that means that in 2035, we're going to have if you can see where my pointer is, we're going to have 47,300 OBGYN physicians in supply, but we're going to have a demand of 53,090. So we're going to have a shortage of somewhere in the neighborhood of 5,500 OBGYN physicians in 2035. And this last part right here that I'm showing is called percent adequacy. And it's a very nice way to really compare the supply and demand. And you would read that in this case as the projected supply of OBGYN physicians in 2035 is going to be sufficient to meet only 89% of the projected demand that we have in 2035. And I'd like to show you, but we just don't have time to go through some of the other aspects of this dashboard. I will note that there are data where available by state. So if you'd like to see how your state is doing or some neighboring states, you could go to the dashboard and click on US map and see what's available. But I did want to highlight one other dimension of the data that especially for OBGYNs is especially important, and that's the rurality of it. So this one, the data that I just showed you is for all OBGYN physicians. If we look at metro, so these are OBGYNs in metropolitan areas, you can see that there's still going to be a similar story of a decline in supply and an increase in demand. But instead of an 89% adequacy, here it's 93%, meaning that the supply is going to be adequate to really meet 93% of demand for those in metro areas. Unfortunately, for non-metro areas, it is a different story. And they are, their percent adequacy is much, much lower. So in non-metro areas in 2035 for OBGYN physicians, the projected supply is going to meet only 54% of the projected demand for OBGYN physicians. So again, this is just a very brief overview of how you might want to, how you could go in, use these workforce projections that we have out there, and potentially identify some areas where resources could be expended to hopefully eliminate or mitigate some of these projected shortages in the future. So I'm going to stop sharing right now and go on to the last part of what I'd like to talk about today, which is some of the work that we did recently on the maternal workforce. So last year, we did a brief on, NICWA did a brief on the state of the maternal health workforce. And I've posted that in the chat in case you are interested. And I might be a bit biased when I say this, but I think we did a very nice job pulling together data from a lot of different places to try to provide some information and context around the maternal health workforce. And some data points really don't need context. And I included this one here, that 10,278,619 women in 2020 lived in US counties that had no OBGYN physicians. So that just gives you an idea of the work that is still needed to be done to make sure that in this case, the maternal health workforce, but just women's health in general, to make sure that everybody has access to this type of care that they very much need. And on the next slide, just to close things out, I wanted to highlight one other aspect that we went into for the maternal health workforce, but it's also more broadly applicable to women's health workforce and to the health workforce at large. And that is really the composition of the workforce and the composition of those with who they are serving. So you can take a look at right here in the two leftmost numeric columns, we have a breakdown by the race or ethnicity of the providers, maternal physicians and maternal registered nurses. And on the right, we have a 2018 breakdown by race ethnicity of the female population ages 15 to 49, and also a similar one for 2030. And as you can see here, the composition of those providing care is different than those who are receiving care right now and who will need care in the future. So, for example, Hispanic or Latino clinicians make up only 7.5% of maternal physicians and 14.3% of maternal registered nurses. However, they were serving in 2018 a female population ages 15 to 49 that was 20.5% Hispanic or Latino. And in the future, it's going to grow even more, 20 to 23.6. So again, this is just very important to make sure that there is a skilled, geographically equally distributed workforce that is also culturally competent to meet the needs of the current and the future population with whom they are going to serve, with whom they serve. And here's my contact information. We're going to do questions at the end of all three of our presentations. But if you'd like to reach out after, please feel free to reach out to me via my email. I'd be more than happy to help and provide any or to answer any questions that you might have. And thanks so much for the opportunity to be here today to chat about this very important topic. Thank you.
Thank you, Steve. It is my pleasure to introduce our second speaker, Shauna Lively. Shauna has spent over 40 years in perinatal nursing in West Virginia. With high-risk obstetric experience, LeMay's certification, administrative leadership in maternal infant care at West Virginia University, and as associate professor at West Virginia Wesleyan College, she has a broad base of practice in maternity care. Since 2009, she has been the Director of Outreach Education at the West Virginia Perinatal Partnership, the state's quality collaborative. In August 2021, she was named Director of the HRSA West Virginia Our Moms Project to provide innovative solutions to enhance access to maternity care within an 8-county area in the heart of West Virginia. She is the past chair of the West Virginia section of the Association of Women's Health, Obstetric, and Neonatal Nurses. Shauna holds a certification as a LeMay's childbirth educator and is a member of the LeMay's International Board of Directors. I'll now turn it over to Shauna Lively.
Thank you. And I'm a grandma and a coal miner's daughter. What else can I tell you, right? Okay, so we were looking at applying for this grant at the West Virginia Perinatal Partnership. And I thought, there's no way that we are going to get it. This is a small rural state, a small area. What can we do? And we just decided to go for it. And much to my surprise, we were awarded that grant. So I want to share my passion with you and let you know what we've done in the past year to hopefully affect some change. Next slide. Pregnancy is a window into women's health. I think we need to remember that as we go forward and not just think of the pregnant person, but the rest of the life and that of the child's. Next slide. So in West Virginia, we have about 18,000 births per year. And I look at McGee Women's Hospital up in Pittsburgh, my colleague's state there, and they probably have 10,000 births in McGee Hospital, just that one hospital. So that gives you a perspective of how rural we are. We have about 3,000 fewer births than we did a few years ago, but that's a trend throughout the nation and globally as well. We have high rates of obesity. More than 60% of people are above that 25 BMI. So we have gestational diabetes, we have hypertension, and we have a lot of cardiac disease too. We are basically white. We have only 3.5% Black moms and fewer than 1%, I believe, Asian, and we have some Hispanic. So we are basically white population. That means that we have to dig a little deeper to reach out to our sisters that are not of the majority race. Our main disparity is poverty. Next slide. So here we have the 7th highest C-section rate, and all of these things are up: preterm births, low birth weight, very low birth weight, teen birth rate, and infant mortality. Now, our maternal mortality is about middle, 20 highest. That's nothing to brag about, but it can still be improved. But the most devastating thing I think that we have, and this is among behaviors, is substance use disorder. And in 2009, we had a study. We did an umbilical cord study where all the cords were just thrown in some form, sterile water, I believe, and sent off to a lab. We had about, I can't remember, eight hospitals in our state. And surprisingly, it came back that 19.4% were positive for illicit substances. We also have a smoking problem. Tobacco usage is very high. As a matter of fact, it's the highest in the nation for pregnant women. Next slide. So we applied for the grant, like I said, Missouri, Minnesota, West Virginia. We have been in contact with each other, sharing some ideas, and we decided to do this project to see if this plan would work. We were thinking that if we did some social support, yes, getting those OBGYNs into our areas is very important, and the mid-level providers as well. But we wanted to render some social support to see what would happen. Next slide. So the goals of the Our Moms Project is, of course, improve maternal and neonatal outcomes. That's foremost of what we do at the Perinatal Partnership. Develop a sustainable network and have a safe environment for delivery and specialty care for these mamas, and to have a sustainable financial model, because all three of the first three really are impinging upon that financial support. You always have to have money for your programs. Next slide. Okay. In 1976, I was about a junior in nursing school at a very small college. And when I graduated, I worked in a delivering facility, one of the 36 in West Virginia. Next slide. Now you can see we went from 36 delivering hospitals down to 20 birthing facilities, 21 if you count our freestanding birthing center in Charleston. So you can see what the problem is. This is my passion right here. Put your hand in the middle of West Virginia. There's no OBGYNs. There are no hospitals that deliver babies. right before about 2016, we had a hospital in Summersville, West Virginia, in Nicholas County. You'll find that there's two little parallel lines, if you can see, CAMC Women and Children's and the Women's Birth Center. Right there, the parallel lines, it's Nicholas County. And when they closed that facility, there were some unintended consequences. Next slide. This is a drive time map. The lighter the area, the more time they have to drive. So the light blue area is 90 minutes. And we're talking about a mountainous area in West Virginia. So that 90 minutes would be on a good sunny day. Can you imagine having to drive 2 hours to a delivering facility? I tell you what, my sister almost had her baby in the car. The doctor didn't even have time to take off his jacket. He delivered my nephew just by reaching out. Fortunately, got his gloves on in time to deliver the baby because it took her an hour and a half to get to the hospital. Next slide. Here is our target area, right in the middle of the state. And you can see up at the top, the little purple stars are our two level 1 birthing centers or hospitals. Excuse me. And it looks a little bit like a Pac-Man there because Clay County was not deemed rural, and whoever made that rule, they'd obviously never been to Clay County. Next slide. So this all too busy slide shows, number one, improved maternal and neonatal outcomes. This is what we've done at the Perinatal Partnership throughout the past 10 years or so. We've developed programs, we've written grants, we've gotten funding to do an incentive program for a tobacco-free baby and me. It gives diapers and wipes to these moms to quit smoking, and it works. It's a good program. We have drug-free moms and babies from another SAMHSA grant. We have 17 sites now in West Virginia to help these mothers get off of their substances. We do medication-assisted treatments. We have counselors, peer counselors, and this program is fantastic, and it has really helped keep families together. And we have a breastfeeding institute now, and we're really working to increase our breastfeeding rate. Before it was like 11%, and now that's up maybe 35% exclusive. So we're really working on that. And now today, actually, I'm here in Charleston teaching a childbirth education seminar because we want to decrease C-sections and improve preterm birth. So we have many of these programs. Next slide. We're leveraging this, what we have done in the partnership, and pushing it out to these rural areas. We had it before, but our Mom's Money has enabled us to push it out even more and increase our serve. So we're going to be working on telemedicine. Some people have telemedicine, some people don't. So we're going to push it out a little bit more into the rural areas. We work with hospitals, FQHCs, and clinics to get this done. And one of the things that I'm most passionate about is mother navigators, perinatal navigators. Sometimes they're called community health workers in that navigator role. At first, I thought they'd have to be nurse navigators, but you know what? It's hard to get a nurse navigator in some of these areas. So let's do what we have, train people, grow our own resources there. Now, we've been around to non-delivering hospitals' emergency rooms. We show them what it's like for a pregnant woman to come in. Maybe her blood pressure is 160 over, that's my timer to tell me to be quiet. But anyway, it tells the mother, we have to tell them to watch that 160 over 90 blood pressure, for example. Emergency room physicians are like, well, so what? Well, that's a critical level for an OB patient. A woman could seize, she could have a stroke. So we have to educate our fellow providers. Next slide. And here's something I thought was interesting from Kaiser is they did almost every other visit for antenatal care by telemedicine. So I thought that this would be an interesting way that we could expand those few OBGYNs that we have. Next slide. And here we're trying to develop a sustainable network. We break silos. This is a picture of us training some people on emergency birth and how to improve their services. Next slide. So the wording that is in blue tells what we have done this past year. We've put about 3 community health workers / navigators into rural areas. We've increased our OBGYN by 1 day a week in a rural area. We have a women's health nurse practitioner that is now going to see OB patients in a very rural area. And we have 1 certified nurse midwife that is coming to the Cowan Clinic once a week. Next slide. Finances. We have a payers group that meets quarterly. And the last time we met, which is I think last week, we talked about doula care, how important doulas are. And so I'm trying very hard to convince them that they need to reimburse for doula care. So wish me luck. I think I can do it. Next slide. And here we are breaking down some silos. This is a group of clinicians. It ranges from obstetricians to nurse midwives, nurses, community health workers, right from the start, home visitors. And these people are coming together. They're writing on a giant poster that we made of each county and adding libraries, diaper banks, food resources. Next slide. But we have to break down those silos. Now, I have a success story. There is a mama in Cowan, West Virginia, that is about 2 hours or so from Charleston. And she was very grateful because Webster Hospital, a non-delivering hospital, decided to have a midwife there in their Cowan clinic 1 day a week. And so this mom was able to see the midwife for all of her prenatal visit. And I was there for a postpartum visit. And it was phenomenal. We had a healthy mom, a healthy and happy baby. And so I just thought that that was a big success story. She was doing great. And she didn't have to miss work. That would have been 10 days that she would have been missing work. And she didn't have to. They worked with her. Next slide. This is our iconic New River Gorge Bridge. Please come visit us at the New River Gorge. It's our newest national park. So our Surgeon General, Dr. Murthy, he has a wonderful vision. He wrote a book, Together. And one of the sentiments is we rise by lifting each other. We have to be together. We have to take care of each other. Medical care is very important, but that supportive care is essential. Thank you. And thank you for having me.
Thank you so much, Shauna, for sharing all that information about the West Virginia Our Moms program.
My pleasure.
Next, I'd like to introduce our final speaker, Dr. James Ryan, Associate Vice President of Women's Health Services at Union Community Health Center located in the Bronx. Dr. James Ryan attended medical school at the Universidad Autónoma de Guadalajara and completed an OB/GYN residency at Maryland General Hospital. After residency, Dr. James Ryan worked as medical director of family planning and was the clinical chief of women's health services at Harlem Hospital Medical Center for over 21 years of his 30-year professional career. Currently, Dr. Ryan is the Assistant Vice President of Women's Health Services at Union Community Health Center. Dr. Ryan finds that he always gravitates to the communities in need of healthcare, striving to be a caregiver to women in need and to treat and educate so as to assure wonderful outcomes and a better life. I will now turn it over to Dr. Ryan.
Good afternoon, everyone. Thank you for having me. In celebration of HRSA's National Women's Health Week, I want to say or give a belated Happy Mother's Day to all the mothers out there and to thank them. So today I'm going to be giving a brief presentation on improving postpartum care compliance. It is going to be brief because as a result, the issues involved in postpartum care are numerous and hard to address in a short time period. But I will briefly present some of the disparities, variables, and obstacles preventing the achievement of optimum postpartum care and focus on some of the steps that Union Community Health Center is initiating to achieve that optimum goal. So with this slide, I'm going to go, as I said, go through some of the disparities, variables, and obstacles. Now, a lot of my talk will be centered about or from New York statistics. So multiple agencies such as the New York State Expert Panel on Postpartum Care, the New York State Task Force on Maternal Mortality, and the New York State Department of Health and Mental Hygiene have been tracking mortality rates over the years. In 2001 to 2003, there was a mortality rate of 25.6 per 100,000 live births. In 2014 to 2016, that number dropped to 18.9. And in 2016 to 2018, it dropped even further to 16.8. Now, though this all might seem encouraging, during the same time period, the ratio of pregnancy-related mortality is 9.5 times higher in women of color compared to white women. In 2014, 2016, the mortality rate nationally for women of color was 44.4, with the same percentage of only 17.3 for white women. In New York State, during the same time period, the mortality rate was 51.6, as compared to only 15.9 in white women. New York State continues to be challenged by increased rates of maternal mortality, ranking 23rd in the nation. In a state with our finances and resources, this is not a good show for us to be 23rd in the country. With these statistics, it's obvious that a disparity in maternal health is occurring in the areas of high need, and we need to close that gap. The variables significantly associated with non-attendance for a postpartum visit include having Medicaid or no insurance, being Hispanic or Latino, having a vaginal delivery, and age of less than 20 years. A substantial proportion of women do not attend at least one postpartum visit, potentially contributing to maternal mortality, as well as preventing a smooth transition to future well women care. Unfortunately, mortality rates increase after delivery due to cardiac diabetes. And so that is where the numbers are high. That's how important it is to get these women into postpartum care. Nationally, less than 60% of Medicaid enrolled women attend their postpartum visit. The obstacles that these women encounter for trying to attend their postpartum visit: lack of transportation, inadequate childcare, no paid time off from work, and other social and cultural complex issues. All of this just highlights the disparity in access to postpartum care and the importance of identifying variables and obstacles within the community, as well as developing creative strategies within the system of providing postpartum care outside of the traditional postpartum visit framework. Enhancing services to meet needs such as treatment for depression, utilizing PHQ-9 initially and throughout obstetrical care, addressing barriers related to transportation and childcare, and aligning incentives to encourage follow-up of postpartum care among patients and providers. Postpartum is care essential to maternal and infant health. Social, environmental, cultural, and financial issues have only increased since the global pandemic. Medicine must also needs to adjust to these changes. At Union Community Health Center here in Bronx, New York, we have been faced with these hurdles and are striving to create a well-being maternal and infant health center to assist and promote the best care and outcomes for our mothers and babies. How are we going to do this? Well, first and foremost, we have to listen to our clients and the concerns and needs of our patients. How are we going to do this with these innovative approaches? Well, quality improvement methods. 3 gaps in postpartum follow-up process are patient education, appointment scheduling, and communication between delivering and postpartum providers. We as providers are joyed and elated and also relieved after a celebratory birth of a loved one, but our job doesn't end there. ACOG's new guidelines are that all women should ideally have contact with a maternal care provider within the first 3 weeks postpartum for initial assessment with ongoing care as needed, and then concluding with a comprehensive postpartum visit no later than 12 weeks. Patient knowledge, that is probably one of the key. We as providers are so centered on the pregnancy and just reaching that goal of a optimum delivery that we forget about the issues that occur and the need after delivery. We need to initiate the importance of postpartum care at the onset of obstetrical care and continue to educate throughout the pregnancy, letting these women know that it just doesn't end with the birth of their child. Appointment scheduling, be proactive. Automatically and appropriately schedule postpartum patients as a reminder to the patients and to the staff, so that when patients don't show up, we reach out to them, inquire why, and try to get them back into care. Communication, it's so crucial to establish tight communication and collaboration with community hospitals to ensure the continuity of care for all our patients and instill trust in them to us for our healthcare. Work with these hospitals, interfacing through their EMRs, and to increase the continuity and follow-up. As it has been more evident since the pandemic, utilize telehealth or even telephonic visits to those patients who are not able to present for their postpartum, for at least an initial analysis and a preventive health visit, with anticipation of trying to get these patients in for an in-person visit. How are we going to do this? Well, after getting all these foundations and being able to bring these women in, Union Community Health Center plans on launching the Maternal and Child Health Center, which will provide a one-stop comprehensive healthcare model for mothers and children to receive the primary care and specialty services they need, such as OBGYN, pediatrics, behavioral health, and dental, plus more, all on the same day in the same location, ensuring that access is equitable and effortless. Utilizing combination visits will help increase that access to care and also the compliance for both the mother and child to follow up on these visits. Kind of incorporating the clinics of pediatrics and obstetrics, we can work and have a camaraderie between our providers, our ancillary staff, so that when patients are being seen by a pediatrician, if a mom has a question, if we're all working in the same basket, you might want to say, pediatricians will be a little bit more aware of the need of what a postpartum woman might need. And us as OBGYN providers will be a little bit more aware of what an infant might need. And this is a great collaboration. And with being in the same area, we can bounce off one another. There can be cross-training between the ancillary staff, between the MAs or the PCAs. And obviously, as obstetricians, gynecologists, we will learn from pediatrics, and pediatrics will learn from us. So the goal of this clinic is to address the issues I've mentioned earlier, and through innovative incentives and initiatives, and ultimately increase that access to healthcare in areas of high need. Thank you, and I appreciate you giving me this opportunity to speak.
Thank you so much, Dr. Ryan. In our remaining time, I'd like to open it up to questions. We do have one question in the chat that, Shauna, it's directed towards you. In West Virginia, are the mother navigators reimbursed by insurance or the grant?
The grant, and we have to work for the next 2 years to try to talk the insurance companies into reimbursement of this very important role. And I totally agree with our last speaker that it would be wonderful to have a one-stop shop for these moms.
Mm-hmm. Yeah, I think that's very innovative, having one-stop shop where they can go with their babies, with their young children, have their appointment, children's appointment, same time.
Right.
And as a follow-up to that question, Shauna, they in the chat, they asked, are your discussions for Medicaid and private insurance reimbursement for both doulas and mother navigators?
Well, right now I have been working on doulas, and we had a Unicare grant that gave us over $100,000 to train doulas. We did not have very many doulas in West Virginia, and now we have gone through DONA, Doulas of North America, to help these women who want to, and many of them are women. I think we have one man that want to become doulas. So we're really happy with that Unicare provided us with that funding. And we look forward to providing, I think we have 60 now that have taken the training. And we have birth doula and postpartum doula. So I'm happy about that.
Excellent. And Steve, I actually have a question for you, because you did mention during your presentation as well that HRSA does have additional data on other providers. Could you expand a little bit more on that and what the data can be used for?
Absolutely. So when it comes to either the data I showed in ARF or our projections data, we have in our projections, we have over 100 different occupations, I think 39 separate types of physicians, nurses, different types of behavioral health providers, which of course is something that there's been a lot of interest in lately. So pretty much if there's a position out there, we probably have some type of data for it. So yes, please do feel free to reach out to me. And just to kind of build off of one of your other questions, we actually just fielded a sample survey, our 2022 national sample survey of registered nurses. So we're going to be getting data in hopefully later this year, knock on wood, everything goes smoothly. And that will give us really a fantastic glimpse of the impact of the COVID-19 pandemic on a lot of different things, to the largest single occupation out there, registered nurses in the workforce, everywhere from things like the impact on working hours, wages, and probably more importantly, burnout, and what the effect is, not only of the immediate effect of the pandemic, but sort of longer term effects of the pandemic, of what that could mean for people staying in the workforce, and if they want to move to different types of positions, either outside of nursing or within nursing. So that's just an example right there of another piece of workforce information that we have. And I just encourage anybody, if there's anything you need on it, please feel free to let me know. If we don't have it here in NICWA, and if it's in another place, I'd be happy to direct you to that resource too.
And Dr. Ryan, I have a question for you, and Shauna, feel free to answer as well. You both have been in your respective fields for over 30 years. And in that time, the technology has changed, new healthcare recommendations, science has changed. But what are you most excited for around innovations in women's health, looking for the towards the future and now?
Well, I'm going to first say I'm very anxious and actually looking forward to that whole idea of the maternal and child health center. I think, as some of the presenters have mentioned, with the years ahead and provider shortage, healthcare will be faced with some very hard times in terms of providing the best care to our patients. And I think by having a center open up where we need to start combining maybe departments, not stay so isolated where it's always a matter of, oh, refer to the primary medicine, or the surgeon, or this and that, that we need to use a model that's going to be the most efficient for the providers and get the most out of the limited providers that we have. And that means opening ourselves up and coming out of our little cocoon to understand other departments and maybe work with them a lot closer than we have in the past. Being in medicine as long as I have, there's always been a great collaboration between departments, but I feel that things are going to be squeezed a little bit more, and we need to kind of step out of our little box and be willing to kind of start doing some of the things outside of our specialty.
Thank you, Shauna.
I agree wholeheartedly with that. You know, I think that we could have a model that would maybe solve a problem with the limitation of OBGYN physicians. There is a family practice, family medicine opportunity that one can go and get certified for obstetrics. That means that your family practice doc can do C-sections because, you know, he or she could use, do the labor, the delivery, and do a section as needed. So this is a very good combination if the family medicine person is interested in doing maybe women's health. And in a small rural area, this is particularly wonderful because they could see all kinds of different patients, and maybe the baby and the child and the grandma. That's what family docs do. And I see that as a win-win. If you had an obstetrician, a family medicine with that specialty, a nurse midwife, I think that that would be lovely. Have a pediatrician there. And of course, behavioral health. I think that would be a very good scope for providing the care that's needed.
Great. We have time if we do one question very quickly, we'll answer. We have a question about how you support mothers with domestic violence, and if there are any newer effective partnerships with local or state domestic violence programs. Can any of you all speak to that?
I will say that there are plenty of resources out there for women involved in domestic violence, or even any issues between mom and children. New York, fortunately, has a hotline that when a provider feels that there is an issue between mom and child, or the mother is in a situation where it's uncomfortable or in a domestic violence situation, for them to be able to be referred and help as quickly and expeditiously, you might say, for them to be able to get out of the situation. This is something that's a little out of, say, my specialty, but this is what we need to do. We need to open ourselves up more and include ourselves in more of behavioral health issues. With the pandemic, I have noticed, I will say, that mental issues in women has increased as it has throughout the nation and throughout the population. So this is an important thing that we need to address and be in the forefront.
Thank you, Dr. Ryan. And I will pitch as well that HRSA Office of Women's Health, we are really excited that during this week, we were able to launch a new 2023 to 2025 intimate partner violence strategy that HRSA will be using across our different bureaus and offices to address intimate partner violence. And that is available now on our Office of Women's Health website. With that, I'd like to thank all of our speakers today for their time and their wonderful presentations. Thank you all for attending today. And I'll put up how you can connect with HRSA further. Thank you all for your time today, and happy National Women's Health Week.